Hello everyone and welcome to this session with me, Dr. Vyshnavi. I hope I'm audible and visible to all of you. Okay, so hi everyone, welcome to this session and I hope I'm audible and visible to all of you. Yes, so good evening. So many of you have already messaged me good evening. So good evening to all of you and I hope all of you are doing really well. So there's a question that can we get the PDF after this session? So yeah, I mean you can get the PDF, but I don't know if the company policy allows it or not. But if you don't get it, then let me know. I can share it with you directly as well. So I mean, hopefully there should be no problem in sharing the PDF of this session. But it'll be good if you can just keep answering throughout the session because then that will make it an interactive one and we will be able to, finish 100 one-liners quite quickly. These are simple one-line questions which you should be able to recall and recollect, in your exams. Right? So are you all ready? So shall we all begin the class? If I'm audible and visible, kindly give me a thumbs up so that I know that I'm audible and visible to all of you. Yes, right. So let's begin with the session. Muscle which is responsible for opening the eustachian tube. So I'll keep reading the questions. Meanwhile, you can keep answering, for the next subsequent. Like for example, I'm on question 1, you can keep answering for 2 and 3 also. So whatever questions are on the slide, you can keep giving the answers. Don't wait for me to read out the question because there will be a lag of 10 to 15 seconds and I don't want to waste that time. So keep answering. Okay. So the muscles responsible for opening the eustachian tube. So it's not tensor tympani. It's not tensor tympani. For opening the eustachian tube, see, whenever our ear is blocked, when we are on a flight, what do? We swallow, right? We do yawning. Why do we do this? Because our palatal muscles get active. And which palatal muscles will open the eustachian tube? It is tensor veli palatini and levator veli palatini. So don't get confused. It's not tensor tympani. It is tensor veli palatini and levator veli palatini. So the only clue you'll remember is eustachian tube is always collapsed. So when we want to open it, when we are on a flight, what do? We swallow, we yawn, and for swallowing and yawning, which muscles are active? Palatal muscles. Which palatal muscles? Tensor veli palatini and levator veli palatini. That's how you're going to remember it. Now, what is coloral fistula? It is due to anomaly of which arch? Quick. So we know that embryologically we have got 5 arches. Each arch on the outside has got cleft. On the inside we have got the pouch. The first, the second, the third, the fourth, the sixth. We don't have the fifth one because it disappears. So the cleft of the first arch gives rise to external auditory canal and the rest of the cleft will fuse to form cervical sinus. This cervical sinus will normally disappear, but if this persists, what will happen? There will be a communication between the external auditory canal and cervical sinus, which we call it as coloral fistula. So it's an anomaly of which arch? It's an anomaly of the first arch. Okay, the stapes develops from which arch? Except for its footplate and annular ligament, which develops from where? Yes, I can see so many of you are answering. So the stapes develops from the second arch. So the stapes suprastructure, to be even very specific, the stapes suprastructure develops from the second arch except the footplate of the stapes which develops from the otic capsule. Easy, I'm sure all of you got this. Let's go to the next one. The cochleariform process on the middle ear is related to dash wall. So if we know that cochleariform process is there in the middle ear, it is related to dash wall is the question. Quick, I'm waiting for your answers. Yes, so we know that cochleariform process is a projection that we have on the medial wall of the middle ear. Usually you get confused with pyramid. Pyramid is on the posterior wall. Cochleariform process is on the medial wall. What is the landmark for the first genu of the facial nerve and second genu of the facial nerve? Again, a very important question. So facial nerve enters from the inner ear to the medial wall of the middle ear, and when it does so, it takes a turn, which we call it as the first genu. Then it runs horizontally on the medial wall of the middle ear, and from there it takes a turn and goes to the posterior wall. So this turn we call it as the second genu. So the landmark for your first genu is going to be the cochleariform process. And for the second genu, what is the landmark you see on the projection on the posterior wall? What is it? It is your pyramid. Easy. Now, can you all quickly revise what is the landmark for the horizontal segment of the facial nerve? It runs above which window? Above the oval window. Below which canal? Below the lateral semicircular canal. And then we have this vertical segment of the facial nerve. This vertical segment of the facial nerve, the landmark is a suture. This suture is present between the middle ear and the mastoid behind. So what will it be called as? Middle ear is called as tympanic cavity, mastoid is behind. So what do we call this suture as? We call this as tympanomastoid suture. So for vertical segment, what is the landmark? It is your tympanomastoid suture line. So I hope everyone is now clear with the landmarks of the facial nerve. Now let's go to the next one. Dash is used as a surgical landmark to locate the mastoid antrum. So what do we use to locate the mastoid antrum? Quick, quick, quick. I'm waiting for all of your answers. Yes, very good. The Mac-Evans triangle is used as a surface landmark for locating the mastoid antrum. Now, where does the inner ear lie? We know that it lies in which bone, but what is the name of that bone, and specifically which part of that bone? Yes, I'm waiting for all of your answers. Where does the inner ear lie? I'm waiting for your answers, guys. Very, very good. So keep answering as soon as you see the questions flashing on the slide. Don't have to wait for me to read out the question because we don't want to waste more time. So we are going to do it fast. The inner ear lies in the petrous part of the temporal bone. The cochlear implant is placed in dash compartment of the cochlea via dash membrane via a dash approach. So they're asking you, you will place the cochlear implant in which compartment of the cochlea? Scala vestibuli, scala media, or scala tympani? Very good. It is placed in the scala tympani of the cochlea via which window? Via the round window. And what is the approach called as? This approach is called as posterior tympanotomy, also called as facial recess approach. What is it called as? Facial recess approach, also called as posterior tympanotomy. Okay, so that's about it. Let's go to the next question. The dash is the most common route of infection in acute suppurative otitis media. So ASOM or any middle ear disease will happen most commonly through which route? Quick, quick, quick. And what is the most common site of perforation of the tympanic membrane in ASOM? So in ASOM, we have different stages: tubal occlusion, pre-suppuration, suppuration, resolution. And we see that usually in the stage of resolution, we see that there is a perforation. So this perforation is located in which quadrant? Yes, so the Eustachian tube is the most common route of infection, and the site of perforation in the tympanic membrane is usually the antero-inferior quadrant. In serous otitis media, a dash incision is made in the dash quadrant of the tympanic membrane, and the first line of treatment for these patients will be. So in serous otitis media, what kind of incision? Will you do a radial incision? Will you do a curvilinear incision? What will you do? Yes, I'm waiting for your answers. Yes, in ASOM, we do a curvilinear incision. Here, we do a radial incision, Kushi. Okay, so here we do a radial incision in which quadrant? We do a radial incision in the antero-inferior quadrant, but ASOM, we do a curvilinear incision in the posterior-inferior quadrant. And the first line of treatment for otitis media with effusion is not directly surgery. It is wait and watch. For how long? for 3 months. If it does not resolve, then you're going to do myringotomy. Along with myringotomy, you're going to insert brome and treat the predisposing factor. If it is adenoid that is causing this, then you're going to do an adenoidectomy. Okay, so what sign is specific seen in acute mastoiditis? So in acute mastoiditis, which sign is the specific sign? So in acute mastoiditis, we see multiple signs. We see lighthouse sign, we see pulsatile otorrhea, we see reservoir sign. But which sign amongst these signs is the specific sign, which is not seen in ASOM? Yes, ironed out sign is the first sign. Okay, Abid, it is not the specific sign. Ironed out appearance of the mastoid is the first sign. But if they're asking you specific sign, then it is your reservoir sign. So reservoir sign is seen only in mastoiditis. Okay, it is not seen in patients with ASOM. So reservoir sign is seen only in mastoiditis. It is the specific sign. Lighthouse sign, pulsatile otorrhea are seen in both ASOM and mastoiditis. Got it? Everybody is clear? The first sign that we see is ironed out appearance of the mastoid. Great. Now let's go to the next question. Glomus is a dash tumor. Is it a benign tumor or a malignant tumor arising from dash cells, presenting with what clinical signs? And dash sign on CECT and dash sign on MRI. Yes. Quick. So glomus is a benign tumor or a malignant tumor? Yes, very important. It's a benign lesion arising from which cells? They are very specific cells, right? Glomus bodies are what? They are paraganglionic cells. Paraganglionic cells are cells of which nervous system? They are cells of sympathetic nervous system. And what do they secrete? They secrete catecholamines. Very good. They secrete catecholamines. Now, they present to you with which clinical sign? See, there's one specific sign where you see that there is a red reflex from the floor of the middle ear. What is that sign called as? Yes, it is called as rising sun appearance. Also, we have one more sign where on increasing the pressure in the external auditory canal, the tumor vibrates vigorously and then becomes pale. It becomes brown. What is that sign called as? Yes, it is called as brown sign. And of course, on compressing the artery, carotid artery, the tumor again becomes pale. What is that sign called as? Aquino sign. So these three are going to be your clinical signs that we see in patients with glomus. But what is the sign that you see on CECT? I have seen so many people, Anukriti, very good. It is the Phelps sign. Very good, Khushi. It is the Phelps sign where you see that there is erosion of bone between the carotid and jugular that you see on CT scan. And on MRI, there is an appearance. What is that appearance called as? Salt and pepper appearance that we see on MRI. Okay, so simple. Almost all the signs are done here. Okay, now let's do the next question. The dash cranial nerve is earliest involved in acoustic neuroma, and there is a dash sign in acoustic where you see that there is hypoesthesia of dash wall of external auditory canal because the tumor has affected the sensory fibers of dash nerve. So in acoustic neuroma, first tell me which cranial nerve is affected first. It starts from your vestibulocochlear nerve, from the vestibular nerve, from the inferior vestibular nerve. That's the origin of the tumor. So if they ask you origin, of course you're going to write inferior vestibular nerve. Now, the nerve that is earliest to be affected because of compression, which will be that nerve that is going to be involved, affected, or earliest that is seen? Very good, Anukriti. It is your fifth nerve that is affected because the sensory roots are very susceptible to compression and earliest to be compressed, presenting to you again with loss of corneal reflex. Now, what is this sign where there is hypoesthesia of the posterior wall of external auditory canal in the region of concha? When you put sensation here in the region of concha, they are not able to appreciate the the sensation. What is that sign called as? Very good. It's called as Hitzelberger sign. Wonderful, all of you. So what is the sign called as? Hitzelberger sign. And this occurs because of involvement of which nerve? So Hitzelberger is because of involvement of the seventh nerve. Which root of seventh nerve? Sensory root of seventh nerve. Now, what is the gold standard for diagnosing acoustic neuroma? Which is the investigation that will tell you definitely that there is acoustic neuroma, and you see an ice cream cone appearance in that? What is that investigation? Is it CT? Is it MR? Is it plain, or is it contrast? Yes, I'm waiting for this answer. Yes, it is MRI, but plain or with contrast? MRI with contrast is the investigation of choice, and it is the gold standard for diagnosing acoustic neuroma. So MRI with contrast. What is the contrast called as? Gadolinium contrast. Okay, so it is the investigation of choice for diagnosing acoustic neuroma. Now, on acoustic neuroma, you see on histopathology, there are two cells. There are some specific cells that we see. Spindle-shaped cells. What are they called as? They are called as Antony type A and Antony type B cells with Verrucay bodies. These are specific names that we see in patients with acoustic neuroma. Done? Okay. Now let's go to the next question. The dash division of the facial nerve is also called as. So basically, I'm trying to ask you, what is the sensory division of the facial nerve called as? Nerve of? What is it called as? The sensory root of the facial nerve is called as? Yes, very good. It is called as nerve of Frisberg. The facial nerve is sensory nerve, motor nerve, mixed nerve. What is it? Yes, it is a mixed nerve. The auricular branch of the vagus nerve is also called as? What is the name of this nerve? The auricular branch of the vagus nerve is called as? Where you see cough reflex, syncopal reaction happening, what is that nerve called as? Yes, this is called as Arnold's nerve. Dash is the tympanic branch of the glossopharyngeal nerve. What is it called as? Middle ear, we have got the tympanic plexus. The tympanic branch of glossopharyngeal nerve is called as? Jacobson's nerve. Very good. Next question. Upper part of the nose is bony or cartilaginous. Lower part of the nose is bony or cartilaginous. And the external nose is made up of how many paired bones and unpaired bones? The cartilaginous part is made up of how many paired and unpaired cartilages? Quick. Yes, so the upper part of the external nose is bony, where it accounts for 1/3. The lower part is cartilaginous, where it accounts for 2/3. The external nose is made up of how many paired and unpaired cartilages? It's made up of 3 paired cartilages: upper lateral cartilage, lower lateral cartilage, and sesamoid cartilage. The unpaired cartilage is one, which is your septal cartilage. It's made up of 2 paired bones: nasal bone and ascending process of maxilla, and 1 unpaired bone coming from above, which is called as your frontal bone. So easy? Yes. Now, dash plexus is situated at the dash part of the nasal septum, and it is most common cause of epistaxis in children and young adults. So, which plexus is responsible for epistaxis in children and young adults? Yes, it is the Kieselbach's plexus. Is it located anteriorly or posteriorly? This is called as Little's area also. Yes, it is located in the antero-inferior part of the nasal septum, and this plexus receives contribution from all the arteries except? Yes, very good. It is the posterior ethmoidal artery. Dash is due to persistence of bucconasal membrane. When bucconasal membrane persists, it results in what? Normally, the oral cavity and the nasal cavity are separately developing. Between the nose and oral cavity, there is a membrane called as bucconasal membrane. Normally, they should disappear, but if it persists, what will it result in? Yes, very good. Choanal atresia. Can anybody tell me what is the syndrome associated with choanal atresia? What syndrome is associated with choanal atresia? Yes, in choanal atresia, we see a syndrome which is called as charge syndrome, where C stands for coloboma iridis, H stands for heart defects, A stands for atresia, which is choanal atresia. R stands for retardation, which can be growth or mental retardation. G is genital abnormalities, and E is ear abnormalities. Please don't make R for renal. It is not renal. We don't have renal abnormality. And E is not esophageal. This is very, very important. Don't get confused. Now, what is the staging system used for JNA? What is the name of this staging system that is used for JNA? Quick, quick, quick. This has been a PYQ come last year itself. So tell me, what is the name of the staging system that we use in JNA? Yes, Redkowski's is one that is used, but there's one more. Redkowski's and fish classification. So last year they asked about fish classification. They did not ask about Redkowski's. So they said the staging system used for JNA is, they had given fish, they had given TNM, then they had given two more options. So you had to recognize that fish is also a staging system that is used in JNA. What technique is used in choanal atresia where a feeding nipple with a large hole provides a good oral airway? So in an emergency, when a child is just born having choanal atresia, presenting to you with stridor, what technique will you use? Yes, this technique is called as McGovern's technique. Now, McGovern's technique is a feeding nipple that consists of a large oral airway with which the child can feed and breathe simultaneously. What maneuver is used for accidental inhalation of foreign body? Very, very important, which is a common repeat question which comes in every exam. What maneuver will you do if a patient is presenting to you with a foreign body inhalation? They'll give you history of peanut, they'll give you history of coin, whatever. What maneuver will you do? Very good. First you will do is the Heimlich's maneuver. Can you do Heimlich's maneuver in 6 months, 1 year, 2 years? Yes, you can do Heimlich's maneuver. It's just that the procedure is different, but you can do Heimlich's maneuver. In children who are 2 years and above, we give compression from behind on the xiphy sternum and back blows. In children who are younger, like less than 6 months, you can put the child in supine position and give compressions on the sternum, or you put prone and give back blows. These are different variations that you do in children who are lesser young. But if they ask you a question, Heimlich's maneuver is the first maneuver that you do if there is a foreign body inhalation. It should never be done when there is a complete airway obstruction. Where the patient is having complete airway obstruction, there you don't do this. But otherwise, this is the first step that you do for any accidental foreign body that has gone into your airway. Now, what maneuver is used for the diagnosis of BPPV? So tell me, for BPPV, what do you use for diagnosis and what do you use for treatment? Yes, very, very good. This is again a common repeat. Dix-Hallpike is used for diagnosis, and for treatment you use Epley's maneuver. If I ask you in BPPV, which is the most common canal to be affected, what will your answer be? Which canal is most commonly affected in BPPV? See, Dix-Hallpike and Epley's are done most commonly for your posterior semicircular canal BPPV, because that's the most common canal that is affected. Okay. For horizontal cushy, we will not do Epley's maneuver. We have other maneuvers for horizontal canal BPPV, like a Lempert's barbecue maneuver. We have Guffoni's method. They are done for lateral canal BPPV. Okay, for posterior canal, we do Epley's, Semonts. These are the maneuvers that we do for posterior canal BPPV. What test is used for assessing the patency of the internal nasal valve? So internal nasal valve is the narrowest portion of the nose. So which test will you do to assess the patency of the internal nasal valve? Yes, very good. It is the Cottle's test that is done to assess the patency of the internal nasal valve. Now, what is the characteristic feature of otitis externa in terms of symptom? They'll give you one specific symptom that is very, very, very specific of malignant otitis externa. Can you tell me what? Yes, very good. Excruciating pain in elderly uncontrolled diabetes. So elderly uncontrolled diabetes, you should think about Malignant otitis externa. What is the sign? Typically on examination, you see something in the external canal. What is it? You see granulation at the bony cartilaginous junction. This is very, very important. They will tell you what is this important characteristic feature. So bony cartilaginous junction, you will see that there are some granulation. What test is used for earliest diagnosis? Which test? This is a radioisotope scan that will give you the earliest diagnosis for malignant otitis externa. What is it? Very good. It is your technetium 99 scan. But when you want to stop therapy, when you want to monitor the treatment, what scan you do? When do you know that you have to stop therapy? No, you do gallium 67 because gallium 67 is taken up by neutrophils. So whenever the disease has resolved, and then what happens, the neutrophils will disappear, hence the gallium 67 scan will be negative, which is why we do gallium 67 when we want to monitor the disease or when we want to stop the therapy. But for earliest diagnosis, you'll do technetium 99. Okay, so in NPC, in areas where with high susceptibility, what is the most sensitive diagnostic marker? What will you do? In those areas where there is a higher probability, like Chinese, Mongoloid population, what will you do? Will you identify against EBV? Are there any antibodies? Yes. IgG or IgM against EBV DNA? Yes, so EBV DNA antibodies are tested to identify if there is any high possibility of cancer in these patients, and that is the, yes, EBV antigen and also antibodies, but antigen is not highly specific. The most sensitive marker will be the EBV DNA. Okay, but if they ask you what is the investigation of choice for diagnosing NPC, then what will your answer be? None of these serological markers, then your answer will be biopsy. Yes, viral capsid antigen, early antigen, and these are the different serological markers that we use, like viral capsid antigen, you use early antigen, all of them. But the antibodies are more sensitive than the antigens in whenever we want to identify in areas with high susceptibility. Okay, DASH is a granulomatous condition caused by DASH and presents to you with nasal obstruction, epistaxis, and a polypoidal mass that resembles strawberry. So they're telling to you that this is a granulomatous disease presenting to you with a mass with bleeding and nasal obstruction. What is it? Very good. It is your rhinosporidiosis. So rhinosporidiosis is caused by Rhinosporidium seaberry. This is airborne, waterborne, foodborne. How does one get infected with this? Now everyone is going to Kumbh Mela. Somebody got infected with Rhinosporidium seaberry, happens to take a dip in that water body, and then there will be thousands of people taking the dip in that same water. Is there a possibility that they can have rhinosporidiosis? Yes, so it's via water. Rhinoscleroma, what is the biopsy finding? Two typical cells. What is it? Very good. It is called as Miculix cells and Russell body. So if you have Miculix cells and Russell bodies, it is very diagnostic for rhinoscleroma. What incision is used in SMR? What incision is used in septoplasty? What incision is used while doing maxillectomy? And what is the diagnostic criterion that you do for allergic fungal rhinosinusitis? AFRS stands for allergic fungal rhinosinusitis. So it is the Killian's incision that we use in SMR. We use Freer's incision in septoplasty. For maxillectomy, the name of the incision is called as Weber-Ferguson's incision, and the diagnostic criteria that we use for diagnosing AFRS is called as Bent and Kuhn's criteria. So what is it called as? Bent and Kuhn's criteria for AFRS. So these names are very important. Killian, Freer, Weber, Ferguson, Bent and Kuhn, Redkowski's, and then your fish. All of these names are very, very important, and you should be able to revise them. What is the key distinguishing feature that separates your septal abscess from septal hematoma? What feature will tell you that this is an abscess and not an hematoma? Two important features. In abscess, there will be fever, but in hematoma, there will not be fever. In an abscess, there will be lymphadenopathy. In hematoma, there will not be lymphadenopathy. These are two very, very specific features which will separate an abscess from that of hematoma. In both of them, they will have nasal obstruction, swelling on either side of septum. They will have pain on the dorsum of the nose. They might have headache, but fever and lymphadenopathy sets apart septal abscess from hematoma. What is the most common cause of septal perforation? Quick, quick, quick. Why does septal perforation happen? Miculics and Russells are seen in rhinoscleroma, not in rhinosporidiosis. In rhinosporidiosis histopathology, you will see sporangia with spores. Okay, Abid? And rhinosporidiosis, you'll see sporangia. Within them, there will be multiple spores like this. Yes, trauma is the most common cause of septal perforation. The most common site of involvement of septum in syphilis is which part? Bony part or cartilaginous part? Quick, quick, quick. This is again a PYQ asked multiple times. In syphilis, which portion of the septum is affected? Bony part. In rest of the other granulomatous conditions like lupus, tuberculosis, leprosy, it will affect which part? Cartilaginous part. And in vaginous granulomatosis, it will cause perforation of entire septum, the bony and the cartilaginous septum. This is again a PYQ. Samter's triad consists of asthma, aspirin sensitivity, and nasal polyps. Right? This is very, very important. They'll give you clinical scenarios over a Samter's triad. They'll tell you a patient presented to you with nasal polyps, which drug should be avoided, and then you should know that it should be aspirin. Okay? The most commonly fractured bone of the face is which bone? So which bone of the nose is the one that commonly gets fractured? Yes, it is the nasal bone. Which fracture results from a blow that is coming from below? So whenever there's a nasal fracture, we have two fractures. One fracture where there is injury happening because the blow is coming from below, and one fracture because the blow is coming from the front. So the fracture where the blow is from below, you get a vertical fracture. What is that vertical fracture called as? Yes, that is called as Chevalier's fracture. So what is the name? It is called as Chevalier's fracture. So Chevalier's fracture, the fracture line is vertical. So remember that two vertical lines are there in which name? Chevalier. The fracture line is vertical. It is also called as class 1. One vertical line, right? So class 1 fracture. And the fracture runs from the anterior nasal spine. It runs vertically from the anterior nasal spine upwards to junction of the bony cartilaginous part of the nose. Which fracture is the second most fractured bone of the face? You know the most common is nose. Now second most is? Second most, what is this bone? Yes, it is the zygomatic fracture, also called as tripod fracture, because we have three fracture lines: zygomatico-frontal, zygomatico-maxillary, and zygomatico-temporal. At these three suture lines we have fracture, so it is the second most frequently fractured bone. Which forceps is used to reduce the nasal bone fracture? See, for nasal septum we have one forceps, and for nasal bone we have one forceps. See, Walsham's is for nasal bone. Ashes forceps is for septum. Okay, so Ashes forceps is for the septum, whereas Walsham is for the nasal bone. What is seen in the orbital floor or blowout fractures of the orbit, where the orbital contents will herniate into dash antrum? What is this? Which sign? Radiologically, what is the name given to that sign where there is yes, very good. This is called as teardrop sign. It is seen in orbital floor fracture where the where the orbital contents will herniate into maxillary antrum. What is the sign seen in CT scan of glomus jugular tumor? We've just discussed, but just let's revise this once more. Yes, we've already discussed. It is the Phelps sign. Dash sign or dash sign is anterior bowing of posterior wall of maxillary sinus, which is pathognomic of dash. Okay, I'll give you, this is also called as antral sign, also called as Hallman-Miller sign, which is a common repeat seen in which condition? JNA, juvenile nasopharyngeal angiofibroma. What classification is used for maxillary fracture? Khushi, glomus jugular and glomus tympanicum, both of them are glomus tumors only. It's the site of origin that is different. Glomus tympanicum comes from the tympanic plexus, which is there on the promontory, whereas glomus jugular comes from the jugular foramen, from the sympathetic plexus, which is there over the jugular. Okay. Yes, so the Leafold's classification is used for maxillary fractures, and Ongren's classification is used for, Ongren's line is a line drawn from the medial canthus to angle of mandible. Any malignancies of the maxillary sinus above it will have poor prognosis, but below this will have good prognosis. So it is a classification for maxillary cancer for prognosis, to understand the prognosis. Right. Inverted papilloma has got different names. What are the different names? Inverted papilloma is also called as Ringer's tumor. It is also called as transitional cell papilloma. It is also called as Schneiderian papilloma. Yes. The pharynx extends from the dash to the lower border of dash cartilage, and it continues as what? So pharynx extends superiorly from where? It's a continuous tube, right? From where does it come? Yes, Khushi, inverted papilloma has a cerebriform pattern. That's true. So pharynx extends superiorly from the base of skull, inferiorly up to the lower border of which cartilage? Yes, up to the lower border of cricoid cartilage, and it continues as the pharynx will continue. Nasopharynx, oropharynx, hypopharynx eventually will continue into esophagus. Very good. There are scattered throughout the pharynx in the subepithelial layer. We have got some lymphoid tissue like adenoid, tubal tonsils, lingual tonsils, which are aggregated spaces, which are aggregated places to form masses. What are these called as? What is this ring? Yes, very good. Shailesh, it is called as Waldeyer's ring. Very good. What is the most common site of malignancy in, site of carcinoma in nasopharynx? Where does the carcinoma originate from? We know that it is nasopharyngeal carcinoma that is the most common cancer, originating from where? From fossa of Rosenmuller. That is the most common site. What type of voice? You get muffled speech, thick speech, often seen in peritonsillar abscess. What is that voice called as? A potato voice. Very good. Hot potato voice. Rhinolalia aperta causes a hyponasal or hypernasal? Aperta, where there is an increased nasal resonance. It causes a hypernasal voice. Very good. So Rhinolalia aperta causes a hypernasal voice. Rhinolalia clausa gives a nasal twang in the voice. Okay, here we get a hyponasal voice. Why do we get this? Because of obstruction in the nose or the nasopharynx. So any airway obstruction, nasal or nasopharyngeal airway obstruction, you will get this hyponasal voice. Primary investigation for adenoid hypertrophy. How do you diagnose adenoid hypertrophy? Of course, with history, with clinical examination, all of that. What is the primary investigation for diagnosing adenoid hypertrophy? Yes, X-ray which view? You will ask for X-ray lateral view of the nasopharynx. That will give you the adenoid size. What is the non-traumatic atlantoaxial subluxation that happens following adenoidectomy called as? What is the syndrome called as? Yes, very good, Sneha. It's called as? Very good. This is called as Griesel's syndrome. Very good. So Griesel syndrome is non-traumatic atlantoaxial subluxation, which happens or can happen after adenoidectomy. Absolute indication for tonsillectomy. Which are the two absolute indications when you should definitely do a tonsillectomy? Two absolute indications. Number one, number two. Quick, quick, quick. Yes, if it is OSA, not in adults but in children. And the second absolute indication is if there is a tonsillar cancer. Then the bed of tonsil is formed by dash muscle. The main muscle is your superior constrictor muscle. The classical membrane that you see in diphtheric tonsillitis is what in color? Is it pearly white or dirty grain color? On peeling, the underlying surface will bleed or will it not bleed? Think about that and tell me. Yes, it is grayish white in color or dirty grain color. On peeling, the underlying surface will bleed or not? Yes, it bleeds. So here we get a pseudo membrane. Very good. What causes nasopharyngeal carcinoma and what causes inverted papilloma in terms of virus? Which virus is implicated in NPC and for inverted papilloma? Yes, quick, quick, quick. We just have another 15-20 minutes of session left. Yes, Epstein-Barr virus causes nasopharyngeal cancer and it is your human papilloma virus that is responsible for inverted papilloma of the nose that we see. What is the staging system that we use for NPC? For NPC, what is the staging system? In JNA, we saw it was Fish and Redkowski's. Here, what is the staging system? It is TNM staging or your AJCC classification. Okay. Now, what is the most common presenting feature of nasopharyngeal cancer? Do they present to you with bleeding from the nose? Do they present to you with ear blockade? What is the most common or the earliest presenting feature? Cervical lymphadenopathy. Teeth, yes, unilateral hearing loss is a presenting feature, but the earliest feature when the tumor is very small, where it does not even cause compression of the Eustachian tube, when it is a 2 mm, 3 mm tumor, it presents to you with cervical lymphadenopathy. So here what we see is cervical lymphadenopathy is the most common presenting manifestation, and we see that this is most commonly seen in which triangle? Host triangle. What is host triangle? Host triangle is formed by medial end of clavicle, lateral end of clavicle and junction of neck and shoulder. What is the sensory nerve supply to the posterior part of the tongue? Posterior 1/3 of the tongue, what is the nerve supply? So if we see the anterior part, anterior 2/3 of the tongue is supplied by lingual nerve, general sensory, whereas the posterior 1/3 is via the glossopharyngeal nerve. The special sensory for the anterior 2/3 is via the chorda tympani nerve, but there is no such special sensory in the posterior 1/3. It is done by the glossopharyngeal nerve only. All the motor muscles are supplied by your hypoglossal nerve. Okay. Now, except the palatoglossus muscle. So I think everyone is clear about this, that here posterior 1/3 is supplied by which nerve? It is by the glossopharyngeal nerve. What is the hallmark finding in otosclerosis? Again, a very important MCQ. Yes. The notch is called as Gerhardt's notch, where you see a dip in which curve? AC curve or BC curve? BC curve. At what frequency? At 2000 hertz. This notch we call it as Gerhardt's notch. Angiofibroma is histologically benign tumor or malignant tumor. Is it locally invasive or non-invasive? And it originates from which foramen? Yes, quick. Angiofibroma is a benign tumor or a malignant tumor. It is the most common benign tumor of the nasopharynx. But even though it is a benign tumor, it is locally invasive tumor and it is most commonly arising from which foramen? Sphenopalatine Foramen. What is the most common presentation of angiofibroma? In angiofibroma, the presenting feature, because it's extremely aggressive and the blood vessels do not do not have the muscular layer, they present to you with bleeding. So bleeding is the most common presenting feature. What is the investigation of choice where you see anterior bowing of the posterior wall of the maxillary sinus, which we call it as the Hallman-Miller sign? Where do you see this Hallman-Miller sign? Yes, it is the CECT. Can we see Hallman-Miller even on X-ray? Yes. What is the treatment of choice for angiofibroma? What should we do? We have to embolize. So embolization followed by surgical excision. This should be the treatment of choice for angiofibroma. So I think angiofibroma is revised. Now let's quickly go to stridor. In dash type of stridor is seen in supraglottic lesions. What type of stridor is produced if the lesion is in thoracic trachea, primary and secondary bronchus? And what type of stridor is seen in the lesion of the glottis, subglottis and cervical trachea? Yes, so whenever supraglottic lesions, you get inspiratory stridor. Anything inside your chest, like your thoracic trachea, primary and secondary bronchus, you get expiratory stridor. And whenever there is a lesion of glottis, subglottis, and you get this biphasic stridor. What is the most common congenital cause of stridor? And here, what kind of epiglottis will you see? Yes. Laryngomalacia is the most common congenital cause of stridor. And what do we see here? What kind of epiglottis? Yes, omega-shaped epiglottis. What is the grading used for subglottic stenosis? Again, very, very important. What is the name of the grading system? It is called as Cotton Myers classification. 0 to 50% is grade 1, 50 to 70 is grade 2, 71 to 99 is grade 3, and complete obstruction is grade 4. What is the safety muscle of the larynx called as? Which muscle is responsible for respiration, for abducting the vocal cord? What is that safety muscle of the larynx called as? Yes, it is the posterior cricoarytenoid. The only intrinsic muscle of the larynx that is lying outside the laryngeal framework, what is this? It is an intrinsic muscle lying on the outside. What is it? Yes, cricothyroid. What is the only muscle receiving dual innervation going from one arytenoid to another arytenoid? It is a single muscle, but it receives innervation from the right side and the left side. What is this muscle? Yes, this is your interarytenoid, also called as transverse arytenoid. What is it called as? Interarytenoid, also called as transverse arytenoid. Stridor is a feature of which nerve palsy? RLN palsy, SLN palsy. First, you should think about that. Unilateral or bilateral? Yes, very good. Stridor is a feature of bilateral recurrent laryngeal nerve palsy. Emergency access to airway is achieved via. See, whenever there is a bilateral recurrent laryngeal nerve palsy and patient is coming to you with stridor, you have to get an emergency access by piercing a membrane. What is that membrane? A membrane that extends between the cricoid and the thyroid. Yes, cricothyroid membrane. And if you still can't get an access, what should you do? Tracheostomy. Okay. So in an emergency, first you try to do a cricothyrotomy, because if the patient is coming to you with stridor, it takes some time to do tracheostomy. So try cricothyrotomy. If cricothyrotomy does not work, then you go and do the tracheostomy. Okay. Pitch and tone of voice are affected in which nerve palsy? SLN or RLN? In which nerve do you see that the pitch of the voice is gone, tone of the voice is gone? Yes. Galen's anastomosis is sensory or motor? See, we know the larynx, upper half of the larynx receives the sensory supply from the internal laryngeal nerve, and the lower half receives from the recurrent laryngeal nerve. So these both nerves form an anastomosis on the larynx. This is called as Galen's anastomosis. So it is between the sensory fibers of the superior laryngeal nerve, which we call it as the internal laryngeal nerve, and the recurrent laryngeal nerve. Now, tuberculosis will affect which part of the larynx? Anterior portion of the larynx or posterior portion of the larynx? So, TB larynx will affect which portion? Yes, very good. It affects the posterior part of the larynx. Now, in TB larynx, we see the first sign. What is the first sign? There is redness of the vocal cord and there is decreased mobility of the vocal cord. That is your first sign, which is hyperemia and decreased mobility. Then we see that there is swelling of the arytenoids. What do we call this as? We call this as mammillated arytenoids. Then we see that there is small ulcers which are discontinuous with each other. We call this as moth eaten appearance, rat bitten appearance. And finally we see that the epiglottis is swollen. What do we call this as? We call this as turban epiglottis. Right, these are the different signs that we see in TB larynx. Okay, then most common salivary gland tumor is, it is your pleomorphic adenoma. Yes. The most common congenital midline neck swelling. What is that swelling that is congenital and midline? Which moves with protrusion of swallowing, protrusion of tongue and also with swallowing. What is that? Yes, it is the thyroglossal cyst. Diplophonia is seen in which condition? Vocal polyp or vocal nodule? Diplophonia is a feature of vocal polyp. Microlaryngeal surgery is the treatment of choice in vocal polyp, whereas in nodule we can wait and watch. Ulcer on one side and heaped up epithelium on another side is seen in which condition? You see that there is an ulcer on one side, there is heaped up epithelium on one side. What is that condition called as? It is called as contact ulcer, also called as pachyderma laryngitis. What is it called as? Pachyderma laryngitis. Now, microlaryngeal surgery is a surgery where we use microscope to remove the lesions on the vocal cord. It uses a focal length of how much? 400 nanometer. Gutsman pressure test is a test where we give compression on the thyroid cartilage and ask the patient to speak and look for any improvement in the voice. It is used in which condition? It is used in the diagnosis of puberphonia. Very good. Keyhole appearance of the vocal cord, where there is weakness of the thyroarytenoid, weakness of the interarytenoid gives this appearance. We call it as keyhole appearance. It is seen in phonoasthenia. So in phonoasthenia, we see that there is a keyhole appearance of the vocal cord. Adductor spasmodic dysphonia happens due to spasm of which muscle? Thyroarytenoid. Abductor spasmodic dysphonia happens due to which muscle? Posterior cricoarytenoid. For spasmodic dysphonia, the treatment of choice is, so it's not a local laryngeal pathology, it's a neurological pathology that is causing spasm of the laryngeal muscles, secondary to Parkinson, Alzheimer. So we cannot think of treating the neurological pathology, but instead what do? We treat the local larynx by giving some relaxant injections, which is nothing but botulinum toxin injection. So botulinum toxin is injected. Ludwig's angina is cellulitis or abscess of which space? Yes, Ludwig's angina is a cellulitis or an abscess? Yes, I'm waiting for answer. It is cellulitis. It's not an abscess. Of which space? Of the submandibular space. A classic sign where you palpate and you see that there is a feel. What is that feel? It is woody hard on palpation and it is always bilateral. It is not unilateral. What muscle divides the submandibular space into two compartments? Which muscle? Which is called as the diaphragm of the floor of mouth. Yes, very good. Mylohyoid muscle divides the submandibular space into two compartments. If airway is endangered in Ludwig's angina, can we intubate? No, the tongue will fall back. So what should you do? You should do a tracheostomy. So if the airway is endangered, what do you do? Tracheostomy. Which are the two parts of the inferior constrictor? We have oblique fibers and we have horizontal fibers of inferior constrictor. Oblique fibers are of thyropharyngeus and horizontal fibers are of cricopharyngeus. Very good. Zenker's diverticulum is also called as true diverticulum or a pseudo diverticulum. See, whenever we have this area, triangular area of dehiscence, we call this as Killian's dehiscence. And if there is outpouching of mucosa, we call it as Zenker's diverticulum. It's not a true diverticulum, it's a pseudo diverticulum. What is the diagnostic test for diagnosing CSF rhinorrhea? Which is the investigation of choice for diagnosing CSF rhinorrhea? It is beta-2 transferrin. If beta-2 transferrin is not there in your option, then you have to mark beta trace protein. Onodi cell, is it an anterior ethmoidal cell or a posterior ethmoidal cell, and it is seen in relation to which nerve? Yes, very important, very commonly asked repeat. Yes, it's a posterior ethmoidal cell seen in relation to which nerve? Optic nerve. Very good. What is an objective? See, this is an objective test, not a subjective test to assess the respiratory function of the nose and nasal airway. See, I'll put a spatula and ask the patient to breathe out. I'll see misting. That is a subjective test where the patient is giving response. Examiner is looking for the inference, but I'm asking for objective test. Particular PTA is a subjective test for hearing. I'm asking for objective test for nasal airway. It is called as rhinomanometry. What is it called as? Rhinomanometry. It is an objective test done to assess the nasal function. Lautenschlager's operation is done for what? Lautenschlager's operation is a surgery where we try to medialize the lateral wall of the nose. So we push the lateral wall. This wall, we are trying to push it medially so that we can reduce the nasal airway. That surgery is called as Lautenschlager's operation, which is done for no, not for DNS. See, we are pushing the lateral wall towards the midline. We are not doing anything to it. It is done for atrophic rhinitis. Young's operation, we do modified Young's operation or Lautenschlager's operation. So what are we trying to do? We are trying to reduce down the size of the nose so that there is no dry air current going in and there is no crusting and there is no foul smell. Vedian neurectomy is not a commonly performed surgery, but if you have to cut the vedian nerve, it is done for non-allergic rhinitis, also called as vasomotor rhinitis. So for non-allergic or vasomotor rhinitis, we do this Vedian neurectomy. What does TESPAL stand for? TESPAL stands for transnasal endoscopic sphenopalatine artery ligation. So transnasal endoscopic sphenopalatine artery ligation is TESPAL. Where do you get floating palate and floating teeth? In which type of Lefort fracture do you get the teeth and the palate are disconnected from the facial skeleton? Is it Lefort 1, Lefort 2 or Lefort 3? Yes, in Lefort 1 fracture. What is Guardsman fracture? Guardsman fracture is also called as parade ground fracture, which is fracture of the mandible, where there is symphysis menti fracture and bilateral subcondylar fracture. So we call that as Guardsman fracture or parade ground fracture. When do you say there is a high tracheostomy? If you go above what level will you say high tracheostomy? Normally you do tracheostomy is mid. So normally what we do is mid tracheostomy, which is between second and fourth tracheal ring. If you go above, it is high, and if we go below, it is low. High tracheostomy is indicated for laryngeal cancer. Low tracheostomy is indicated whenever there is a respiratory papillomatosis, laryngeal papillomas. In that condition, you go for low tracheostomy. So with this, we finish all the 100 questions, and I hope that you've been able to revise quickly some 100 one-liners with me. Okay, so if there's anything that you want to ask, please leave it in the comment section below. And if you have any doubt even later, you can reach out to me. I will be more than happy to help all of you. I'll take your leave now, and I will see you all again. Until then, take care and bye.